This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Annals of Medicine, published in 2026. It's titled Association Between Reduced Cervical Extensor Muscle Mass and Postoperative Outcomes After Single-Door Laminoplasty in Elderly Patients with Cervical Spondylotic Myelopathy, a retrospective study.
This is a topic that hits home for those of us in the OR. We often focus so much on the decompression, the bone and cord work, that we might overlook the engine of the cervical spine, the extensor muscles. As our population ages, we're seeing more cervical spondylotic myelopathy, or CSM. In fact, the paper notes that CSM is the most common cause of spinal cord dysfunction in adults worldwide.
Exactly. And while posterior open-door laminoplasty is a preferred approach for multi-level involvement, especially when you have a positive K-line, we know that outcomes aren't always uniform, even with a perfect decompression. This study specifically looked at whether the quality of the paraspinal muscles, specifically fatty infiltration, could predict how these elderly patients fare.
It's an interesting pivot towards sarcopenia. We've seen this in lumbar surgery studies, looking at the multifidus muscle, but this study brings that focus to the cervical spine. Alara, walk us through the patient cohort and how they actually measured muscle quality.
Of course. This was a retrospective review of 116 patients, though they narrowed it down to 101 after exclusions. These were patients aged 60 to 82 who underwent first-time single-door laminoplasty for multi-level stenosis, specifically 3 or more levels. The follow-up was at least 12 months.
And the grading? How did they quantify the fat in the muscles?
They used preoperative MRIs and applied the Gautelier grading system. For those who need a refresher, this system classifies fatty infiltration. They divided the patients into 3 groups: mild, moderate, and severe. The mild group had 45 patients, moderate had 38, and severe had 18.
I think it's important for our residents listening to realize that muscle mass isn't just about the size of the muscle on a cross-sectional area, it's about the composition. If the muscle is replaced by fat, that fatty infiltration, it loses its functional integrity. Now, what did they find in the perioperative phase? I noticed some significant differences in the hospital course.
They did. One of the first things that stood out was the postoperative drainage volume. The moderate and severe groups had significantly higher drainage, about 153.4 millimeters and 145.6 millimeters respectively, compared to just under 100 millimeters in the mild group. This actually translated to a longer hospital stay for the patients with worse muscle quality.
That's a practical point for surgical planning and bed management. But the real meat of the study is the clinical recovery. Did the patients with fatty muscles actually have worse neurological outcomes?
They did, and the numbers are quite telling. At the 12-month mark, the severe group had significantly lower JOA scores, 11.95 compared to 14.69 in the mild group. If we look at the JOA recovery rate, the severe group was at 55.9%, while the mild group reached 68.3%.
That's a substantial gap. And they also looked at the MCID, right? The minimal clinically important difference?
Yes. They found that patients in the severe group were less likely to achieve the MCID for both the JOA score and the Neck Disability Index, or NDI. So it's not just a statistical difference, it's a difference that the patients are actually feeling in their daily lives. Their functional improvement was capped by their poor muscle quality.
You know, this makes sense when you think about the biomechanics. After a laminoplasty, we've essentially altered the posterior elements. We rely on those extensor muscles to support the neck and maintain alignment. If those muscles are essentially marbled with fat, they can't do their job. Speaking of alignment, what did the radiographic data show?
That was one of the most significant findings. They measured the C2-C7 Cobb angle to assess cervical lordosis. At the 1-year follow-up, the severe group showed a much greater loss of cervical lordosis. Their Cobb angle was only 3.57 degrees compared to 7.4 degrees in the mild group.
So the severe fatty infiltration is directly associated with sagittal imbalance postoperatively. As neurosurgeons, we worry about post-laminectomy kyphosis, and while laminoplasty is designed to prevent that, this study suggests that if the patient's musculature is already compromised, they are still at high risk for losing that lordotic curve.
Exactly. The study points out that the extensor muscles act as the dynamic stabilizers of the cervical spine. When they are weakened by fatty infiltration, which is a hallmark of sarcopenia, the spine loses its ability to resist the tendency towards kyphosis after the posterior arch is opened.
It's a bit of a chicken or the egg scenario in some cases. But here, the preoperative MRI clearly served as a crystal ball for the postoperative sagittal alignment. Why do you think the drainage was higher in the severe group?
The author suggests that poor muscle quality might lead to more intraoperative trauma or perhaps just a slower healing response in the muscle tissue itself. If the muscle is less vascularized or more friable due to fat, it might bleed more or produce more exudate after we've detached and reattached portions of it during the laminoplasty.
It really emphasizes the need for meticulous soft tissue handling, especially in these elderly patients. But let's talk about the clinical takeaway. If I'm in clinic and I see a 70-year-old with severe fatty infiltration on their MRI, how does this study change my conversation with them?
The author suggests that preoperative MRI-based muscle assessment should be part of our risk stratification. We can tell the severe group that while the surgery will decompress their cord, their recovery might be slower, their risk of losing neck curvature is higher, and their overall neurological improvement might be more limited than someone with healthier muscles.
And perhaps it opens the door for prehabilitation. If we know the muscles are the weak link, maybe we should be focusing on strengthening or nutritional interventions before they even hit the OR table. Though, as the paper mentions, many CSM patients are in too much pain or have too much nerve impairment to do a full functional muscle assessment before surgery.
That's why this MRI-based Gauthalier grading is so useful. It doesn't require the patient to perform a physical test. The data is already there in the imaging we're already ordering to look at the spinal cord.
It's a very elegant way to use existing data. Now, were there any limitations to the study that our colleagues should keep in mind?
Well, it was a retrospective study with a relatively small sample size, especially in the severe group, only 18 patients there. They also only followed them for 12 months. It would be interesting to see if that loss of lordosis continues to progress or if it stabilizes after the first year.
Agreed. Long-term sagittal balance is key for preventing adjacent segment disease and chronic neck pain. If those muscles are failing, we might see more issues at year 2 or 5.
The study also didn't go into detail about specific postoperative rehabilitation protocols. It leaves us wondering if a more aggressive physical therapy program tailored to the severe group could have closed that gap in JOA recovery.
That's a great question for future research. For now, the takeaway is clear. Don't just look at the cord, look at the muscles surrounding it. Severe fatty infiltration of the cervical extensors is a red flag for poor neurological recovery, more drainage, longer hospital stays, and postoperative sagittal imbalance.
It really highlights that sarcopenia is a word we need to be using more often in the neurosurgery clinic, not just in the geriatrician's office.
Well said. This study provides a solid foundation for better prognosticating our elderly CSM patients. It's a reminder that we are treating a whole patient, not just a set of imaging slices of the spinal canal.
Definitely. It's about setting expectations, both for ourselves as surgeons and for our patients.
That's all the time we have for today. Thank you, Dr. Alara, for breaking down this important paper.
My pleasure.
And thank you all for listening to the Neurosurgery Hub podcast. Stay sharp, and we'll see you in the next episode.